Hey, good afternoon, folks. Welcome and thanks for joining us. Today is National Go Red for Women Day, raising the awareness of heart disease in women. Now, remember that heart disease is still the most common cause of death in women, accounting for 1 in every 5 deaths in women. Now, this is a 3-part series, a collaboration with Cardiovisual and myself, bringing to you 3 different perspectives of paramedics, of patients, and of cardiologists. We'll start off with the paramedic today. Now, Cardiovisual is meant to have a mission to better educate your patients on both heart disease and diabetes, and you can find their educational content at at heart.medicalvisual.com or by clicking the link in their bio. Now, let's go ahead and bring on Stacee, our first guest. Let's see if we can get her on. There's Stacee.
Hi.
Hey, good afternoon, Stacee. How you doing?
I'm doing great. How about you?
No, I'm doing great. All I had today for this event was my red tie, no dress.
That works.
You
Well,
got your red
dang
on,
it.
right?
I do. I'm all red for
All
today.
right. So, our guest, you, Stacee, you're a paramedic, an EMS instructor, an educator, and creator of Lights Sirens Action EMS. And it's my pleasure to bring you on to get your perspective on heart disease in women from a EMS, a pre-hospital standpoint. So, let's get going here. Let's see here. The first thing to talk about is really to understand that heart disease is still the leading cause of death in women. And, from an EMS standpoint, Stacee, I'd like to know your take on this. What percentage of patients having a heart attack are actually women in your practice?
I'll be honest, definitely a lot lower, and I think it goes into that we have those symptoms of in women when it comes to cardiovascular events that sometimes mask as different types of things, which we'll get more into, of course. But yeah, I would say a lower percentage of women seek help in the EMS setting for heart attacks.
Yeah. And so, the question really is, and I don't like this term at all. We've talked about this. I don't like the term atypical symptoms, right? That just means that chest pain is a typical symptom, but maybe it's just the way your heart's speaking out in terms of nausea and vomiting being the same equivalent as chest pain, right, in a heart attack. So the question that I have is, do women actually downplay, even if they're having chest pain, for example, do they downplay their symptoms typically or compared to men in your practice, or what do you think?
I don't think they do it purposely. I don't think women do it purposely, but I do think oftentimes they don't think that their symptoms indicate a cardiac event. They think maybe they have a stomach bug or indigestion or heartburn, and they let it go on too long. And unfortunately, by the time I get to meet them out in the pre-hospital setting, it usually is in a dire situation.
Yeah, what comes to mind? Like, can you recall a story where you actually were on scene and patient had something GI like, right? So I'll tell you what, I had a patient with something similar to this, where they came in after eating seafood, and they said, "I've got a stomach bug. I've got something I ate was not right, and it's the seafood, and I've got something a GI bug." And guess what she's having? An inferior MI. She had no chest pain. All she had was reflux-like symptoms and nausea and vomiting. Have you had something similar to that?
Yeah. Yeah, actually, my first STEMI that I ran on as a paramedic, it happened to be an inferior MI as well, but it was toned out as a sick person. And so when we arrived on scene, the patient did look just that. She looked very, very sick. She was vomiting, very pale, clammy. But we went ahead and hooked her up to the cardiac monitor, knowing that oftentimes in women, it's kind of a sudden onset of this, like we say, these gastric
Mhm.
symptoms. But one of the main things, and you and I have talked about this before, is if it's a sudden onset like that, immediate, like in your case with your patient, if it happened right after she ate, chances are, unless a few hours have elapsed, it's not the food. It's something more serious.
Yeah, GI symptoms from food poisoning are typically 4 to 6 hours later, right? Not out right after eating something, and that should be sort of a red flag to someone who comes in like that after eating something in a restaurant. So, so you've got it right. We all sort of have seen this and all that. But how about the younger paramedics coming through the system now? What is their level of their education? I'm asking you this as an educator. What are you guys doing out there to educate the younger pre-hospital providers to recognize these? I'll go ahead and say atypical symptoms, right? Um,
Right.
what's being done right now?
I would say it starts in the classroom. It definitely starts in the classroom and really teaching, especially when you're going over cardiology, but even in other incidents, women don't always present like our men. And, our men typically, when we're talking heart attacks or cardiac events, they have that crushing chest pain, they have down the left arm, oftentimes up into the neck. And it's usually that telltale, we know what's going on. But women, it's almost always like indigestion or a burning pain rather than a crushing pain like we learn in our textbooks. So I think it really starts in the classroom and just letting the students know that, don't let those symptoms distract you. Don't let the symptoms of, like we talked about, vomiting, nausea, hook them up to the cardiac monitor and check for. And as we know, not all MIs show up on the monitor either. So, err on the side of the caution there where, when you're trying to rule out a cardiac event, don't just assume that, oh, nothing's happening if it's not showing up on the cardiac monitor, on the EKG.
Yeah. I had the tuna case, and my tuna case was a woman who she had a few things working against her. There was a language barrier. So I think she spoke Russian, I believe, and so there's definitely a language barrier. She was older, and she was a woman, and she must have been in her, I think early 80s, and she kept saying bad tuna fish, bad tuna fish, and my intern was, well, this is just classic bad fish syndrome, right? So you go down this rabbit hole and start working on her up for a GI bug and give her, Zofran and Pepcid and fluids. And so her ECG just showed some very minor, we call them non-specific, changes on the ECG. And I wasn't happy with it because it just wasn't fitting, right? It just wasn't something that was right. Plus, she was older and she was a woman. And so she wanted to leave, and I couldn't help but sign her out. And her son actually came in and convinced her to stay. She got admitted, and at 2 a.m., guess what happened? She developed typical symptoms of now chest pain. She had runs of VTAC, and unfortunately, she went to rest and didn't make it. So it is so tricky out there, right? It's so difficult, and the reason why I share that story is because in the pre-hospital setting, you've got seconds, minutes, something very short to really convince them that this is real. This could be cardiac or not, right? So we have hours. You guys have so little time, and that's why I think the education that you do for your paramedic students is just so important, right? To never, never, never just chalk it up to something benign like that because a patient says it's that, right?
Absolutely.
Yeah.
Yeah.
And another point is that women, right? Women actually do much poorer than men, and this is across all ages. I put a question up this morning on what people thought about. I don't know if you saw that. On
I
what
did.
people thought
Yeah.
about how women do compared to men. And the answer is across all ages, and this was looking at ages 45 and up, but really across all ages, Stacey, they do worse than men. Their 1 year mortality is higher. They just do worse. And I think it's an important thing to realize. And what are your thoughts about that? What factors do you think influences that statistic?
I think oftentimes it can be a difficulty in the pre-hospital setting specifically. On the EMS side, we are predominantly male-dominated field, and we have to do EKGs on women patients as well. And there is an anatomical difference. There is a little bit more difficulty when we're getting an EKG, and there's also undergarments that we have to consider, and things of that nature that I could see maybe providers holding off on, or saying, well, we'll just wait till they, we can get them to the hospital and to a higher level of care. I could see that being a problem. I could also, I mean, and you and I have spoken about this, the studies of women getting less CPR. It's an unfortunate truth, and it comes from the fear of, number one, hurting. CPR is a somewhat barbaric looking act, but it's so needed in the times where we've got a pulseless patient, right? But people are scared to hurt women, or they're scared of being accused of assault, or they're scared of things like that. And so unfortunately, it causes these clinical gaps, or these, like we said, poor outcomes
Yeah,
for women.
not just that, but also just to do CPR, to expose the chest, to just things like that also gets to be something that people consider, I think, and I think makes people pause before they actually do something quickly, like CPR, kind of do it right away, right? So, and you talked about anatomical differences between women and men. Is there really a difference in sort of site, IV site access and things like that?
I wouldn't say so much on IV site access, but definitely when getting an EKG, there are anatomical differences, and it may not be as easy to get it on a female than it is a male, but it's totally a doable thing. It saves lives. And when you have a good 10-15 minutes on the way to the hospital, there's really no reason you shouldn't
Oh,
be getting an EKG. And one thing that my friend recently brought up to me is, she said, why don't we see female mannequins very often? And it was such a good point. It's such a good point. How are we going to, encourage people to do CPR when our mannequins, I mean, we do have some female mannequins, but typically it's for obstetric use only. It's not just your run-of-the-mill everyday mannequin. And it's like, we have to get people comfortable on doing CPR on a woman as well.
what's up with that, right?
Yeah,
All the studies, in the past were focused on men, the Fred heart study, and we really neglected to use women as sort of, female mannequins were just not done. At least when I was a resident, we used male mannequins, except for OB/GYN things. And so, what a great point, and what a great point to just make it just have them, right? So people don't take that pause and wait too long before something bad happens. So
absolutely.
great point, really great point. And there's a lot of studies out there now looking and emphasizing the problem there, right, of waiting too long because they're a female. And that may in fact be a huge reason why women have poor outcomes, especially in things
Yeah,
like sudden cardiac arrest, right, where they're in VFib and people just don't act quickly enough. Um,
absolutely.
you know, were you going to say something?
No, I just was agreeing. I absolutely agree. I mean, we have to practice like we perform out in the field, So if we only have one half of the population, if we only have, the male mannequins, then we're not preparing our students in the best way.
Right. Well, we're going to change all that, right?
Right.
We got a red
Definitely.
on here. So yes, great point, Stacey. We touched on this a little bit, but I've been thinking about our discussion about communication, language, and the importance of that. I want to get into this a little bit more, in that we know that when we are in pain, when we are suffering under duress, physical stress, the the assumption is that, yes, the patient heard me. I told them they're having a heart attack. They heard me. In reality, though, we don't know exactly what they actually heard versus what they actually took in, right? Digested. Can we talk about that a little bit?
Absolutely. I think it's so key. It's something that in EMS education is not taught on, how to just break the news of what you're seeing. Like, let's just walk it through a call. If I went on a call, the patient was having a STEMI, I would need to in some situations. There are situations where you would allow you to get into a more controlled environment before you break that news to them. But I think really educating your patient on what's going on, like, excuse me, sir, ma'am, what I'm about to say is probably going to seem very overwhelming and scary, but I can assure you right now, my partners and I are doing everything we possibly can for you. So let me explain a little bit about what I see on this EKG. And, if you want to give the disclaimer, I'm not a physician, but we do have some training in interpretation of EKGs, and unfortunately, it looks like you might be having a heart attack. So what we're going to do is get an IV start and just go through the entire thing just very slowly. You mentioned kind of slowing your speech down. That is so important because it's so much information so fast. And one of the things that I also noticed is that as we're approaching the hospital, just explain you're going to have a lot of people around you very fast, and they're going to be doing a lot of things. And try not to get too overwhelmed, because most of the time they're going to go straight to the cath lab. And I mean, you've seen it. It's like this once you get into the cath lab. So just educating your patients in a slow, simple way, not using huge terms that they have no idea what they mean. And it makes for a scary situation to be less scary.
Right. Even something like STEMI or MI, they
Yeah.
don't understand it, right? So, and I will even back off on that more, saying that, part of communication starts with the unspoken language, right? The body language. So when we are under stress, you and I are working on a patient, and I look at you, and you look at me as a partner, and our faces show anxiety. Now, there are about 42 different muscles of facial anxiety, right? Well, I'll tell you what,
Right.
patients pick up on that quicker than they do on the words we speak. So I think really in the training process, and nobody does this, right? Nobody teaches on this. We try, but we don't get very far. Really, slowing down and just kind of having a more neutral affect when we're discussing things. That's where checklists are great, because you're actually kind of working off a template and not trying to think of getting or reacting to the situation. You're looking and saying IV, O2, monitor, aspirin, heparin. These are all things you kind of do, and it actually kind of makes the entire event more bland for the patient, and they don't react to your anxiety. So I think that it's really important, I think, for patients to not perceive the anxiety, in the provider's reactions, right? So that's one thing. And the other thing is using terminology. You just said this. Yeah, use simple language. Your heart is sick. Something. I think this is all part of education that's really not being done that consistently, or maybe that not that very well either. What do you think? Is there a lot of work to be done there?
Very much so. There's a lot of work. Like I said, I didn't get that type of training of essentially just how to speak to a patient that is experiencing a cardiac event. And you and I have talked about it before. When it comes to the EMS classroom, there's like one chapter over patient communication. It's very dry, bland, and that's it. And you're just kind of left to your own devices out in the field. And so you really have to kind of educate yourself and think also, how would I want to be spoken to in this situation? Would I want my medic or my EMT to look at the EKG and just have these big eyes like, oh gosh, this is really bad? Or would I rather have someone who looked, okay, this is what we're going to do. And get the medication, let the patient know, slowly educate them as you're going through your process, and then get them quickly and safely to the hospital.
Yeah, so true. I was talking to a patient actually, and as a matter of fact, on the gram here, and they're having a heart attack. And I said, "So, what's going through your mind when you heard the paramedic crew speaking with you?" And the answer was, "I had no idea what they're saying. All I saw was anxiety. They were sweating. I was having a heart attack, but I had no idea what they're saying." I said, "Well, did they explain things to you?" "Yeah, but I just shut off." You're thinking about your own anxiety, or what's going to happen to me. You can't really process things. You probably retain, I think, a fraction of what you actually heard.
Yeah.
So it's an important, really important point, I think, to consider when you're taking care of patients in the ambulance, right? So
And I like to say to the patients too, and I don't know if you do this in the ER, but is there someone I can call to meet you? Like in my case, is there someone I can call to meet us at the hospital? Because a lot of patients, they don't have a medical background. And especially in a situation where they're having a cardiac event, they're not thinking clearly. They need an advocate. They need someone to be there for them. And so that's one thing that I'll try to do. And sometimes they'll say, yeah, they're in my cell phone under this. And, myself or my partner, whoever is not doing something at the moment, might just give him a ring and let him know to meet us at the hospital and kind of calm him down a little bit.
Yeah. So, right. I think it's a lot of work done. I think, Cardiovisual has, I think, done something like this, a pilot program where they've tried to introduce the need for clear communication with the patient and what to expect when they get to the ED. So that's really, I think, great work of they're doing. We'll have more of that later on. That's great, Stacey. See, let's go. If you don't have anything else right now, I think we might have some questions coming on the feed board here. Want to take a look at them?
Awesome. Sounds good. Let's see.
Let me see here. Yeah, so it's, one question is, I'm curious to see if there are any particular nuanced differences we see in ECGs of women versus men. ECG differences.
I'll let you answer that one. What do you see in the ER?
I was trying to, yeah, so to answer that question, there really aren't ECG differences except for things like, body haptics can cause, ECG changes. So men being larger, maybe bigger chest, you might see changes in voltage and things like that that might make it more difficult to interpret the ST elevations. And remember, we're not talking about ST elevations, we're about J point elevations, right? So the J point is what we're looking at. And that really is not different except for the definition. So in men, it's 2 millimeters in V2 and V3, and women it's 1.5 millimeters, broadly speaking, right? These are the criteria set in by the American Heart, 2013, I think. But it's not the ST, it's an elevation of the J point. In women, it's a little bit less because of the anatomy, the chest wall anatomy. So there is a slight difference in the definition, but not really in what we see in terms of a STEMI pattern.
Yeah, and out in the EMS field, that's really not something and I'm glad to hear that you say there's not much difference, because we really don't consider a gender when we're looking at the EKG. We're just, a STEMI on a woman would look the same as a STEMI on a man, right, is what I'm trying to say.
There's a question here. It says, how do you know the difference between breast pain and heart pain?
Well, that's good.
What do you think?
That's a good one.
What do you use in the field?
Well, typically I would say, with our now granted, we did talk about women presenting differently, but it would be going through my OPQRST and asking onset, anything make it better or worse? Does it radiate anywhere? Is it just local in the breast in that one specific side? Those are all questions. Also maybe palpating and seeing if, pressing on it makes it worse, makes it better. When you let go, is there tenderness, that sort of thing. What about you?
I'm glad you said that. I'm going to disagree a little bit on that, only because I think, I'm kidding. You're right. Palpation tenderness is important. Mm-hmm. I think looking at the patient's skin, right, is important. You know how many times I've seen zoster present as heart pain? Like, oh, my heart, and it's zoster. It's a rash. And so, I tell my trainees, look at the skin. Look at the skin. It's always first visualizing the skin to make sure there's no rash or an abscess. The abscesses in women's breasts that causing pain. It's really not an MI. It's really something localized to the tissue of the chest wall or the breast. So make sure you look at the skin before anything else. And then palpation tenderness. Let's talk about that. I think that there's some studies out there saying that palpation tenderness is not necessarily a reliable way to rule out cardiac pain. And if you push on the chest wall and it hurts, you can't use that reliably. Something like 3% of patients will actually have an MI when you push. Doctor, don't do that. Please don't push my chest. That hurts. Oh, this is not your heart. Not so true in a small percentage of patients. So be careful, folks out there, when you use that as a measure to rule out something cardiac.
And definitely needs to be the big picture, the full
The
picture,
full
you
picture.
know, checking all.
Plus the other
Yeah.
things, right? The associated symptoms, the nausea, the shortness of breath, all those things too make a huge difference. Here's a question. What about women in perimenopause? Great question, right? Fantastic question. Women in perimenopause, is estrogen cardioprotective? And what are your thoughts on that?
Well, I know we've definitely talked about it for women in menopause in class, just the cardiac symptoms that they can have, the palpitations, the irregular heartbeats,
Mm-hmm.
the physical symptoms. So I'd imagine perimenopause would be similar because the estrogen is starting to drop at that point
Yeah.
in a woman's life.
Yeah. So, I think estrogen has some cardioprotective properties to it. And so when they looked at studies in women less than the age of 45 who are still having their regular menses, estrogen does seem to have some cardioprotective effects. Not everybody, but speaking broadly across populations, that may be true. And so women tend to present what? They present a little later usually. Men tend to present a little bit younger, women a bit later because of that drop off in estrogen after menopause. And the perimenopausal period can be very confusing. I have patients all the time who say, I've had palpitations and sweats and nausea. These are my heart. Can't tell. Can't tell until you work them up. So I work up all those patients. They all need screening, risk factor screening labs, 2 sets of troponins, all those things, because you just can't tell. It's that danger zone, the perimenopausal period, right? Because the symptoms are so confusing. So you see those patients I see?
I wouldn't say that we have placed a lot of consideration on the perimenopause period of life, but it's definitely something that we should because it is more, people are over time becoming more and more educated of just the hormonal changes and the effects that it does have on the cardiovascular system, because it does. It's like you said, hearing that estrogen is cardioprotective makes total sense, because once a woman gets into menopause, they can have some cardiac side effects, some symptoms.
Right, really good. We have 2 minutes to close. Let's take one more question. And this says, is the treatment different for an inferior MI versus other kinds of MI? Pre-hospital version of this.
Oh, okay. In my area, it is still contraindicated if there is right-sided involvement on an inferior MI to not give nitro. You are not to give nitro if there's right-sided involvement. But I'm well aware that the surrounding areas and most of the United States of America are more up to date. And, yes, you do have to be considerate of blood pressure in a patient that's having an inferior MI with right-sided involvement, and make sure that you have IVs and fluid going, just in case you do get that major drop in. And typically those patients, you can correct me if I'm wrong here, Doc, but the ones with the right-sided involvement, they tend to be a little bit on the lower blood pressure side. Not necessarily hypotensive, but just kind of on that edge of, if I give a dose of nitro, I might need a little something to bump them up.
Yeah, we had a case, I think, just a couple of weeks ago. I posted it where a patient was profoundly hypotensive and having an inferior MI. And the question was, do you get nitro or not? And you're right. In inferior MIs, especially that inferior MIs affecting the RV, you can bottom the pressures out by giving nitroglycerin. But I think you got to be careful and kind of, just not overreact either way. So I give fluids first. If they're having GI-like symptoms, I'll first give, my approach is 300 cc's at a time times 3, 300, 300, 300, get the pressure up. And then once the pressure is better, you can think about giving nitrates if the pressure is more normal tensive. If it's not, I switch to pressors. And atropine is a complicated question. Sometimes it works in certain kinds of things, but pressors, norepinephrine is a great one to start with if they're really failing fluids. So great question. We can take that on in a more detailed discussion at a later point because it does have some, I think, some nuances to it and some detail.
Absolutely.
All right. So I tell you what, it's time to stop. Unfortunately, it's been a complete pleasure of ours to speak with you. Any closing
Yes, thank you
thoughts?
so much for having me. No, just thank you so much for having me on. It's been a pleasure as well on my part. And I think, the Go Red for Women needed this attention on it, and we need to, remember that I didn't even realize the statistics of that more women die of heart disease than all of the cancers combined. That was a statistic that I was pretty impressed, but also quite devastating at the same time.
Yeah, true. So hopefully things like this will bring awareness to patients and to physicians and to just people everywhere to say, look, this is something we can actually just kind of look more into, right? And not dismiss these so-called, I'll say it again, atypical symptoms that aren't just chest pain. So thank you so much, Stacey. It's been a pleasure speaking with you. We'll talk to you. We'll talk to you soon in the future. Okay.
Thank you for having me. Bye-bye.
You're most welcome. And folks, thank you so much for joining me on behalf of Cardiovisual. Next week, we speak with Brittany Williams, who's a sudden cardiac arrest survivor. She's a patient. She's a huge advocate for sudden cardiac death and this entire cause we're talking about. So on behalf of Cardiovisual, thanks so much and take care.